Hello, it's Dr. Shelly, and this is part 2 of a 2-part video that talked about when to call the doctor. This video is simply how to call the doctor. In other words, we're going to talk about Sbar, and we're going to talk about the importance of what you do, how you do, when you do it, and whether or not to page the doctor or use the chat. Now, when I say doctor, this could be nurse practitioner, physician assistant, and Sbar can be used with anyone at any time you are transferring the patient's care. So it's used in handoff report. It may be used with physical therapy. It could be used when you transfer the patient to a long-term care facility from a hospital setting, and vice versa. If you're calling the hospital to tell them about a long-term care facility patient. So anytime the care of the patient is being transferred to another facility or caregiver, Sbar is the standard of care. Now, all of this is going to be found, as you know, in management of care. We even have a couple of handouts. The Sbar, which is the reiteration of Sbar, and then the old-fashioned Sbar, and some detailed explanations and some do's and don'ts on informatics. So this will be easy. So if you got your packet, you're ready to roll, let's dive in. Now, the Sbar, which is a reiteration of just plain old Sbar, the I is important because for whatever reason, I know that nurses, experienced and new, get very nervous when they have to call the doctor. Let me remind you of a couple of things. You are intelligent, you are educated, and you are prepared. And that person that you're calling puts their pants on the same way you do and does not pay your rent and cannot fire you. I want to be clear about that because one time I went around the room to ask everybody in the class, can a doctor fire you? The answer is no. If that was true, we wouldn't be empowered and have the autonomy to question their orders. So please get this big, huge weight off your shoulders that this person is up there with God or whatever. They put their pants on like you do. They're a normal human being. And here's the other part. They're your team player. You guys are equals. You want to work with them and they want to work with you, and they respect you when you come correct. So let's come correct. Here we go. Sbar. The I is simply identify yourself. Who are you? And then here's the thing. Make sure you get the doctor's name or PA name or NP name that you're talking to. There is nothing more frustrating in a courtroom when the note says doctor notified and the doctor or doctors say they never were. You never included a name, so maybe they weren't. Your name and who are you talking to? And don't forget, of course, the most important thing, the patient's name. Now, the situation, which is the S part of Sbar, the situation is in a summary, why did you call them, but a little bit more deeper. Think www.y for situation. In other words, W, who, the patient. W, what is going on. The W, where is your patient? As an OBGYN nurse midwife of 20 years, I delivered babies at Hillcrest, University Hospitals, or I should say Cleveland Clinic, Hillcrest, University Hospitals, Mount Sinai, and St. Luke's. That was 4 hospitals. If you were calling me about my patient as a provider and you're the nurse, I need to know which hospital you're at. So don't take that too lightly. Most of the time in a teaching hospital, your providers are all together in that facility, but you cannot assume because even teaching hospitals have independent providers that cover more than one hospital. And then of course, the W for why you called is so important. So that's the what. So what? why did you call me? Like, are we just chilling out on the phone and enjoying life in the big green city of Ohio? No, you called me for a reason. So that is your situation. Again, W, 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 and why. Who, what, where, and why I called. Okay? If you're in the hospital and all the providers are from the same hospital, you need to still give a room number and a floor. I'm in Tower, whatever. I'm in Sideman, whatever. I'm in the ER, Bay 6. Okay. The background is important, but don't go crazy here. Really, don't go crazy. You need the pertinent background. The pertinent background for why you called. The pertinent history, the pertinent medications, even the pertinent IV fluids that are currently hanging, or if there are none, stated as much. The allergies are always important. The surgeries that were recently had, the labs that were recently done or not done. The admission, diagnosis, and date. He came in last night with pancreatitis. He was admitted on January 13th with a GI bleed. You get it. The assessment is, what do you think is going on? What do you think is his diagnosis? And here you get kind of, as a new nurse, you get freaked out because you learned in school some bullshit. You did. You learned that you cannot diagnose. It's all bullshit. You better diagnose, and you better share with your team what your diagnosis is. And I get that you feel strongly that all these years of school you learned that you can't. But then the real world hits you and your doctor does not want to hear nursing diagnoses. And the good news is the nursing diagnoses are not on NCLEX either, because they recognize to some level it's all bullshit. It's just bullshit. Sorry. But so here's where you would say, I don't know, I think he's becoming septic, or I think she has preeclampsia, or this poor kiddo, I really think he's getting pneumonia, or to be honest with you, I think this patient is getting hypertensive, like a hypertensive crisis maybe. I don't know for sure. I think he's got fluid overload, like he could use, I don't know, dialysis. Remember, he missed his dialysis Monday. Or whatever. You have to give this person that you're calling some idea of what your assessment is in terms of what do you think is going on with this patient. And by the way, you may be wrong or not even know what's going on, and that's okay too. I have literally said, I can't figure it out, but I know for sure something's wrong, okay? Here you are sharing the latest vital signs, the latest physical assessment, including pulse ox, lung sounds, if they're applicable, alert and oriented status, if it's applicable, and any nursing actions that you took on your own. You know, I think he's going into respiratory distress. I sat him up. I put him on O2, 2 liters of nasal cannula. Nothing has worked. He's still pulse oxing less than 90. Your recommendation must be super, super duper clear. What do you need or want from the provider that you called, and when do you need it? Sometimes you need it really urgently. I have said, quote me, I have said, I need you to come to the bedside and evaluate the patient. And I need you to write that down, because that's a common phrase that we use when we want you now, all up in our house right now. I need you to come to the bedside and evaluate the patient. It's pretty clear, okay? So this recommendation has another R attached to it that maybe you weren't taught, but I teach you to know the other R. The other R is read back. Okay, so you're on your way to see the patient, doctor, whoever, okay? Okay, so you want me to go ahead and hang LR and open it wide, give them a bolus of 500 cc's, and go ahead and get a VBG and call respiratory? Thank you. Okay, so it's a recommendation and read back. Do not forget the read back. Things can happen really crazily in a healthcare facility, and you could misunderstand in the heat of the moment a lot of things that you needed to hear a lot clearer and misconstrue orders, decimal points, you name it, we can do it. Okay, so this is your Sbar. Now I'm going to give you an explanation of how the new nurse is educated and wise beyond her years if she just would believe it in her heart. This is a shout out to Diane Jackson. I always tell this story because it's so powerful what a brand new nurse can do. So Diane Jackson was working at a neighboring hospital in Cleveland, and we have a ton of hospitals all in the same radius. That's why our salaries are so wonderful. So Diane Jackson was taking care of a patient with COPD. And many of you were taught that COPD can pulse ox less than 90 and be okay. That, again, was bullshit. Yeah, it is. It's wrong. It's absolutely wrong. So you were taught that and it's wrong, and we're going to get over that. And I teach my class that's bullshit. And so Diane Jackson knew that that was bullshit. So she's working with a patient with COPD. She's been out of my class about 12 days. She's in orientation. She's a brand new nurse. She just passed her NCLEX. She tells me that during this day, she had this patient with COPD, and they were pulse oxing below 90s in the high 80s, 86, 87, 88, 89. And that she did all of the things that I've instructed you to do when a patient's pulse ox drops below 90, not to assume that it's okay in a COPD patient. But she did some of those 10 things. Just a quick review on some of those 10 things. I teach you to sit the patient up, positioning. If they're if they're laying back, sit them up into semi-fallers to high fallers. Some people need tripod. So that was one. I tell you to go ahead and change, and if they're not on O2, put them on O2. So O2, turn it up if they are on it, turn them up. I tell you to, if they're on a nasal cannula or nothing at all, and you feel this is respiratory distress based on this pulse ox dropping below 90, to go ahead and put them on a non-rebreather mask, because that's going to deliver nearly 100% of oxygen. So that was 3. I tell you, if they don't have an IV hanging, you need to hang one, and you need to consider if they need fluids, because maybe that's the issue. If they don't have an IV and they're pulse oxing below 90, you better put one in. So that's 4. Then I tell you to go ahead and tell the patient to cough and deep breathe. And these aren't in any order, by the way, except sit the patient up is kind of easy in the first thing, right? But they're not in any order is my point. So if the patient is desatting, as we say, and deteriorating in their saturation, their O2 saturation, we tell them to cough and deep breathe. So take some deep breaths. Give me a couple coughs, depending on if they had surgery or a procedure just done. And I just did it the other day at work, so you know, this is real. We also tell you chest physiotherapy, pats and claps. Maybe put the vest on them if you know they had a respiratory condition to begin with. Let it vibrate and get some of that mucus moving out of their lungs, okay? We tell you to suction them. We tell you to make sure you give them a treatment. And if it's at your hospital where you don't have to do the breathing treatments, then call respiratory to give a breathing treatment. Well, guess what? Diane Jackson had did all of those things, and her patient was still pulse oxing below 90. She talked to her preceptor. The preceptor kind of chuckled at her and said, yeah, Diane, it's normal for COPD to pulse ox below 90. In school, you learn that that's just what they do, and you don't want to give them too much oxygen because you'll kill their respiratory drive and la, la, la. There's just one problem with that. Diane Jackson went to my program, CHELLYS Nursing Review, HETV on YouTube, and she became schizophrenic right at that moment. And when I say schizophrenic, she started hearing voices, but not a lot of voices, just one. And that voice was loud and obnoxious and swearing. That's bullshit. That is some bullshit. Pulse ox less than 90 is always an emergency. Hell to the double no. You better call somebody yesterday, girl. Listen. That's the voice she heard, and it matched mine. So she took her schizophrenic self and started freaking out a little bit because she knows what I taught her, and she knows that I'm passionate about it because everybody's being taught wrong. And then she went to another preceptor. When she went to that preceptor, who wasn't her preceptor, she's a seasoned nurse on the floor. I should have said seasoned nurse. She went to that seasoned nurse and she told them what happened. They laughed her off too. She goes, it's going to be a long career, girl, if you don't know that the COPD patient can pulse ox less than 90 and be normal. Oh, schizophrenia returned, and she kept hearing me screaming in her ear, fuck that shit, that's bullshit, blah, blah, blah. That's what I do. And so she finally decided, you know what? I'm going to go against everything everyone is saying, and I'm going to call the doctor. And she remembered her Sbar when she called to tell me the scenario. She said, you would have been proud of me, Miss Shelly. I knew my Sbar. Good. So she started it off, right? She said, I am Diane Jackson calling from the towers over at such and such hospital. I'm calling about the patient in room whatever. This patient is pulse oxing less than 90 despite everything I did. They were admitted with COPD. They also are a diabetic. They already have IV fluids hanging. It's LR. They're allergic to whatever. And then they came in 2 days ago for COPD. Her assessment she shared with them. In this part, she told them how the full vital sign protocol, she told them the pulse, the temp, everything. She also told them that her nursing actions had not worked yet. She told them that she got him a breathing treatment. She told them that she made him cough and deep breathe, that she tried to suction him, sat him up, put O2 on, gave him a non-rebreather. He's still pulse oxing below 90. That was all this. And then she went into her recommendation. I'm calling you because I'm hoping I can get an order for a chest x-ray and just trying to see what you think. This doctor, and you know, Diane is a brand new nurse. She thought she was going to be fired. She didn't know doctors can't fire you. But this doctor said, after a long pause, you know, long silent pause, and what is your name? She said, Diane Jackson. So she's like waiting to be chewed a new ass. And the doctor said, okay, well, I see that you've done everything I would have told you to do. So yeah, let's get a chest x-ray. Let's get a sputum culture. And then call me back with the results. Well, the results said that this gentleman had a pneumothorax. This doctor wrote a commendation of this brand new nurse, and that commendation stated how most new nurses would not have thought that a pulse ox less than 90 was something to report, and that she's very proud of her and that she saved her patient's life. That patient was transferred to ICU. Diane also got flowers from that nurse, and so she just was beside herself when she realized that whole pulse ox less than 90, so not normal in anyone. Yeah, so remember that. Now, some other things I want to share with you very quickly include, and this is under the other, which provider should you call? Here you have to remember the chain of command, and you are not calling a medical student, so be careful. You are calling the intern always. You don't call the attending. Sometimes it's very difficult to know who the intern versus the attending is, especially on weekends and holidays. Here is where your charge nurse can help you. Also, let me say, when you do bedside report, and you should be doing this, as well as following any lines that the patient has, meaning when you walk in the room, follow every line to the patient. So IV line, where did it go? Central line, where is it at exactly on the patient? Where is this JP drain? Where is this, I thought, Foley bag, but not suprapubic? I mean, where are the lines and where did they lead? What is this tubing? Oh, it's a ureteral stent that they never mentioned, okay? You know, you just will see it all. Oh, look at there. The NG tubing doesn't follow to the patient. It follows to the floor. That would explain why the floor is so sticky and smells like Boost. I mean, you know, that sort of thing happens all the time. So Sbar at the bedside, but also when you are at the bedside, probably the most important thing that your handoff report can include is who is following the patient and who do we call and what consults do they have. Those things are really important because if you're calling about a dialysis issue, then the consult nephrologist would be the one you call, not the primary care. You gotta know this, okay? Now, be prepared. When you get ready to call this provider, sit in front or stand in the patient's room in front of a Epic electronic medical record and have it on your WOW, and then make sure you're looking at the things that you're going to need to know. I would always have the latest labs, and the fact that the labs weren't drawn at all today is pertinent, but I would have the latest labs. I'd have my last set of vitals as I'm waiting on the doctor to call me back. And then when it is an urgency, you need some serious orders related to the patient's care, not a diet order, not a discharge order, not can the patient go off the floor, not can the patient take their own meds. No, you need something related to the patient's care, like that's going to improve their status. That is always a page. And if you're at a Cleveland Clinic system logging into Page the Doctor, please remember to go all the way up to the top and it'll say anonymous until you log in, and then it tracks that page and it'll keep a log of all your pages. Log into your pages, people. This anonymous doesn't get it. Save your chats for very non-urgent issues, diets, discharge orders, patient's family wants to talk to you. Don't put urgent matters in pages. Please, I see that the most. It's absolutely crazy, okay? All right, now, so that's that. Here's 2 examples from yours truly to hope and pray it makes sense. In room 1, there's a patient who all of a sudden has shortness of breath and a sudden cough. It's a maternity patient because I'm trying to hook you up with a little maternity. I'm sneaking it up on you, okay? So here's how this is going to go. I'm calling the nurse midwife and I'm letting her know. This is Shelly from Hillcrest Hospital. I have Mickey Mouse here who delivered a week and a half ago. She's here because she said she cannot lay back without getting short of breath, and she's got a bad cough. She doesn't know if she has COVID or she's got pneumonia or what's going on. Her background includes delivery date of January 5th. She is in the emergency room here with us. She's allergic to penicillin. When she delivered on January 5th, it was a C-section, and this is when I put the pulse ox on her, she pulse ox at 93. The assessment I have for you is that her vital signs are temperature 37, pulse 110, respiratory 24, and her blood pressure is 94/58. Her physical assessment is that her lungs are actually clear, but her feet are very swollen, and she says her left foot hurts more than her right, more so around when she pointed to is more like the ankle. She's with us here now. She is on oxygen because she is pulse oxing 93%. I put her on a nasal cannula, 2 liters. I really think that this is either a PE or CHF. I don't know which one. The coughing makes me worry. The fact that she had surgery makes me think PE. So I don't know, but I do think you need to come and see her right now. So that was that. Okay, let's do another one. This patient is in room 2, we'll say. They have a low blood pressure. Y'all ready? All right. I'm calling you because this is Shelly from Cleveland Clinic main campus. I'm calling you about Minnie Mouse, who is here with me today. They came in the ER about an hour ago. I'm calling you because they have a low blood pressure. They came in complaining of chills. And their background includes that they had their appendix removed 4 days ago here at main campus. They're coming in with an allergy to penicillin. Their appendectomy that they had 4 days ago was uneventful. They just had the Jackson Pratt drain removed 2 days ago. My assessment is her vital signs are temperature 38.3, blood pressure 90/48. Her respers is 22. Her pulse is tachycardic at 110. The nursing actions that I took so far is she's already on oxygen. We have her on a nasal cannula. She is pulse oxing 96%. She is currently looking okay, but yeah, I'm concerned that she could be septic. Okay, so come on in and check her out. You want me to do a VBG and blood cultures, CBC with diff? What would you like? Okay. So these are 2 scenarios made up as I went along, kind of sketch, but I think you get it. The whole point is to show you how to organize yourself when you're giving a report to the doctor or whoever. And I hope this helped. Remember, again, this was management of care. All right, so pink packets, deuces. Oh, if you need anything, I'm sorry, I always forget. If you need anything, I'm Dr. Shelly. You can call 216-410-0936. Remember the video that was done before this one was first nursing action, call the doctor, and actually told you when to call the doctor as a first nursing action. I will link it to this video. Hit the subscribe button. Deuces.